Pain management. 51. Alan F. Call, I Introduction, A Definitions. 1. Pain is an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage or described in terms of such damage. It is a subjective, individual experience that has physical, psychological, and social determinants. There is no objective measurement of pain. In the United States alone, recurrent or persistent pain is experienced by more than 75 million individuals. 2. Acute pain lasts 30 days longer than the usual healing process for that type of injury and occurs after muscle strains and tissue injury, such as trauma or surgery. The pain is usually self-limiting, decreasing with time as the injury heals. It is described as a linear process with a beginning and an end. Increased autonomic nervous system activity often accompanies acute pain, causing tachycardia, tachypnea, hypertension, diaphoresis, and mydriasis. Increased anxiety also may occur. 3. Chronic pain is persistent or episodic pain of a duration or intensity that adversely affects the function or well-being of the patient and can persist after the resolution of an injury. Some define it as lasting more than 6 months. A chronic non-malignant pain may be a complication of acute injury in which the healing process does not occur as expected or may be caused by a disease such as a rheumatological disorder, for example, osteoarthritis, rheumatoid arthritis, fibromyalgia. B. The elderly are more likely to experience chronic pain because of the increased prevalence of degenerative disorders in this age group. C. The pain is constant, does not improve with time, and is described as a cyclic process, vicious circle. D. Compared to acute pain, there is no longer autonomic nervous system stimulation, so the patient may not appear to be in pain. Instead, the patient may be depressed, suffer insomnia, weight loss, and sexual dysfunction, and may not be able to cope with the normal activities of daily living, including family and job-related activities. 4. Chronic cancer pain occurs in 60% to 90% of patients with cancer. Its characteristics are similar to those of chronic non-malignant pain. In addition to depression, prominent characteristics are fear, anger, and agony. The cause of chronic cancer pain can be related to the tumor or cancer therapy, or can be idiosyncratic. Tumor causes of pain include bone metastasis, compression of nerve structures, occlusion of blood vessels, obstruction of bowel, or infiltration of soft tissue. 5. Breakthrough pain is the intermittent, transitory increase in pain that occurs at a greater intensity over baseline chronic pain. It may have temporal characteristics, precipitating factors, and predictability. 6. Neuropathic pain is a result of an injury or malfunction of the nervous system. Excluding patients with a progressive peripheral neuropathy or neuropathic pain associated with a cancer lesion, tissue damage is not ongoing. Neuropathic pain is described as aching, throbbing, burning, shooting, stinging, and tenderness or sensitivity of the skin. 7. Migraine pain is characterized by a severe headache generally associated with nausea and light and sound sensitivity. Migraine is a common disorder with a 1-year prevalence rate in Americans of approximately 13%, ranging from 6% to 7% of men and 18% of women. 1020 Chapter 51. B. Principles of Management. 1. Comprehensive pain assessment should determine the characteristics of the patient's pain complaint, clinical status, and pain management history. A. Assessment of the pain complaint should include chronology and symptomatology of the presenting complaint, such as information about onset, location, intensity, duration, quality, distribution, provocative factors, temporal qualities, severity, and pain history. B. Assessment of clinical status should include the extent of underlying trauma or disease. Also, the patient's physical, psychological, and social conditions should be determined. C. Assessment of pain management history includes drug allergies, analgesic response, onset, duration, and side effects. 2. Appropriate pain management targets should be established. A. The primary pain management goal is to improve patient comfort. B. For acute pain management, improved comfort can aid the healing and rehabilitation process. C. For chronic pain, the specific objectives are to break the pain cycle, that is, erase pain memory, and minimize breakthrough pain. D. Other targets for chronic pain management include improvement of general well-being, sleep, outlook, self-esteem, activities of daily living, support, and mobility. 3. Individualized pain management regimens should be determined and initiated promptly. A. The optimal analgesic regimen, including dose, dosing interval, and mode of administration, should be selected. B. Additional pharmacological adjuncts and non-pharmacological therapies should be added if needed. C. The most common regimens for acute pain include intermittent, as needed, dosing, patient-controlled analgesia, PCLA, or epidural infusions with narcotic or non-narcotic agents. D. Non-narcotic analgesics and non-pharmacological management usually are maximized. Narcotic use may be appropriate for certain patients being treated for chronic non-malignant pain. Pain management specialists often include these agents in their plans. E. For chronic cancer pain, an individualized around-the-clock analgesic regimen is established, using a long-acting analgesic. An intermittent, as-needed regimen for breakthrough pain using a short-acting analgesic is also determined. 4. Monitoring the pain management regimen and reassessment of the patient's pain should occur on a continuous, timely basis. Any changes in analgesic, dose, dosing interval, or method of administration should be noted in the patient's medical record and carried out in a timely fashion. Second, analgesics. A. Non-narcotic analgesics include aspirin, other salicylates, acetaminophen, non-steroidal anti-inflammatory drugs, NSAIDs, selective cyclooxygenase 2, COX-2 inhibitors, disease-modifying antirheumatic drugs, DMARDs, and tumor necrosis factor, TNF, inhibitors, Table 51-1. Aspirin products, acetaminophen, and some low-dose NSAIDs such as ibuprofen, ketoprofen, and naproxen sodium are available as over-the-counter OTC products. 1. Mechanism of action. Salicylates and NSAIDs are prostaglandin inhibitors and prevent peripheral nociception by vasoactive substances such as prostaglandins and bradykinins. Most NSAIDs inhibit both COX-1, which produces prostaglandins that are believed to be cytoprotective of the stomach lining, and COX-2, which produces prostaglandins responsible for pain and inflammation. Selective COX-2 inhibitors like celecoxib do not inhibit COX-1. Adalimumab, etanercept, and infliximab act by binding or capturing excess TNF, one of the dominant cytokines, or proteins, that play an important role in the inflammatory response. The exact mechanism of action of leflunomide, a novel drug used to treat rheumatoid arthritis, is not completely known, but it is thought to inhibit pyrimidine synthesis. 2. Therapeutic effects. A. The peripherally acting non-narcotic analgesics have several effects in common. These effects distinguish these agents from narcotic analgesics. 1. They are antipyretic. 2. They are anti-inflammatory, except acetaminophen. 3. There is a ceiling effect to the analgesia. Pain management 1021. Drug adult dose range, mg. Dosing interval, HR. Maximum dose day, mg. Paraminophenol derivatives, acetaminophen, Tylenol, 325 1004. 6-4000 salicylates, aspirin, 325 1004. 6-4000 choline, magnesium trisalate. Trilicite, 1000, 512, 3000. Default unicyl dolabid, 250, 1008. 12 1500 salsalate disalcid, 500 1008. 3000. Aeropropionic acid derivatives, phenoprofen-nalphon, 204. 6 3000, 200 flurbiprofen, Ansed, 50. 106 12 300 ibuprofen, Motrin, 300 868. 3200 ketoprofen, Orudis, 12.5 75 68 300 naproxen, naproxen, 200 512 1250 naproxen sodium, anaprox, 275 550 12 1000, 375 oxaprozin, Dapro, 600 bone 1000, 212 1200. Heteroaryl acetic acid derivatives, diclofenac, Voltaren, 25 75 6 12 200 ketorolac, intramuscular. Toradol, 15 66 120, ketorolac oral, 10 4 640 tolmetin, tolectin, 200 606 8 1800. Indole and indene acetic acid derivatives, idodolac, lodine, 200 406 12 1200 endomethacin, indocin, 25 58 12 200 Solindac, Clinaural, 150 212 400. Anthranilic acid derivatives, phenamates, meclophenamate, 50 104 6 400 mefenamic acid, Ponstel, 256 1000 alkanone derivatives, nabometone, Ralofen, 1000. A. 12, 24 2000. Enolic acid derivatives, oxycams, piroxicam, Feldane, 2024 20 cyclooxygenase 2, COX-2. Selective inhibitors, celecoxib, Celebrex, 100 212, 24 400. Disease-modifying antirheumatic drugs, DMARDs, leflunomide, Arava, 2024 20 anakinra, Kineret, 100 mg Snapchat 24 abatacept, Orencia, 500 mg for patients weighing less than 60 kilograms, 750 mg for patients weighing 60 to 100 kilograms, or 1 gram for patients weighing over 100 kilograms, 2 to 4 weeks after the FIRST, and then every 4 weeks. Table 50-1 non-narcotic oral analgesics and non-steroidal anti-inflammatory drugs, NSAIDs, continued on next page. 1022 Chapter 51-2. A. 4. They do not cause tolerance. 5. They do not cause physical or psychological dependence. B. The efficacy of non-narcotics is compared to aspirin. Most drugs are comparable to aspirin. However, several NSAIDs have shown a superior effect to 650 mg of aspirin. 1. Diflunisal, 500 mg, 2. Ibuprofen, 200 to 400 mg, 3. Naproxen sodium, 550 mg, 4. Ketoprofen, 25 to 50 mg. C. The newer classes of drugs, in general, have not been compared to aspirin. 3. Clinical use. Generally, the non-narcotic analgesics are used orally to manage mild to moderate pain. 1. They are particularly suited for acute pain of skeletal muscle, orthopedic, or oral dental origin. 2. They are used to treat pain and inflammation associated with osteoarthritis and rheumatoid arthritis. 3. They are used in chronic pain and can have an additive effect with narcotic analgesics. 4. They also may be effective in managing pain owing to bone metastasis. 5. They are used for mild to moderate migraine pain. B. The NSAID ketorolac is administered intramuscularly and is useful in moderate to severe pain, particularly in cases in which narcotics are undesirable, for example, with drug addicts, excessive narcotic sedation, respiratory depression. C. The NSAID diclofenacopolamine is available as a topical patch, Flector patch, for treatment of strains, sprains, and contusions. One patch is applied to the most painful area twice a day, should not be applied to damaged or non-intact skin. D. Patients may vary in their response and tolerance to non-narcotic analgesics. If a patient does not respond to the maximum therapeutic dose, then an alternate NSAID should be tried. Likewise, if a patient experiences side effects with one drug, then another agent should be tried. Several drugs, for example, diflunisal, choline magnesium trisalicylate, naproxen, celecoxib, leflunomide, etanercept, infliximab, adalimumab. F. The cost of non-narcotic analgesics is highly variable and should be considered when an agent is selected. Pharmacotherapy with the COX-2 inhibitor celecoxib, the newer DMARDs like leflunomide or TNF inhibitors is significantly more expensive than older agents. 21. Drug adult dose range, mg, dosing interval, HR. Maximum dose day, mg. Biological response modifiers, tumor necrosis factor inhibitors, adalimumab, Humira. 40 Snapchat injection every other week, TBD etanercept, Enbrel. 25 Snapchat injection. Action once weekly 50 Snapchat injection infliximab, Remicade. 3 kg Ford infusion every 4 to 6 weeks 10 kg certolizumab, Cimzia. 200 mg Snapchat every 2 weeks adalimumab, Humira. 40 mg Snapchat every other week golimumab, Simponi. 50 mg Snapchat, give with methotrexate, every. Others tocilizumab, Actemra. 4 mg kg Ivur infusion over 1 HR. Max 800 mg infusion every 4 weeks. Rituximab Rituxan, 1000 mg 4. Give with methotrexate, every 2 weeks 2 doses. Excludes loading dose of 100 mg day for 3 days. Ivur, intravenous, Snapchat, subcutaneous, TBD. Table 51-1 continued. Pain management 1023. 4. Adverse effects A. Gastrointestinal, GI effects. Most non-narcotic analgesics cause GI symptoms secondary to prostaglandin inhibition. At normal doses, acetaminophen and choline magnesium trisalicylate produce minimal GI upset. Because of their mechanism of action, the COX-2 inhibitors have a GI toxicity similar to placebo. Adalimumab, etanercept, infliximab, and leflunomide have been associated with GI side effects including nausea, abdominal pain, dyspepsia, constipation, vomiting, hematochezia, intestinal abduction, intestinal perforation, pancreatitis, peritonitis, peptic ulcer, and diarrhea. 1. The most common GI symptom is dyspepsia, but ulceration, bleeding, or perforation can occur. 2. Patients most predisposed to severe GI effects include the elderly, patients with a history of ulcers or chronic disease, and those who smoke or use alcohol. 3. To minimize GI effects, the lowest possible analgesic dose should be used. Aspirin, available as enteric-coated products, may minimize GI upset. Combination therapy with a GI protectant, for example, antacid, H2 antagonist, sucralfate, misoprostol, may be needed. B. Hematological effects. Most non-narcotic analgesics inhibit platelet aggregation. The effect is produced by reversible inhibition of prostaglandin synthetase. Aspirin is an irreversible inhibitor. Acetaminophen and choline magnesium trisalicylate lack antiplatelet effects. TNF inhibitors have been associated with anemia, aplastic anemia, leukopenia, neutropenia, pancytopenia, and thrombocytopenia. Leflunomide has been associated with anemia and ecchymosis. 1a. The effect of the NSAIDs correlates to the presence of an effective serum concentration. 2. Use of anticoagulants, for example, heparin, warfarin, Coumadin, is relatively contraindicated in combination with aspirin or NSAIDs. C. Renal effects. NSAIDs can produce renal dysfunction. Etanercept has not been shown to affect renal function. 1a. The mechanism of induced renal dysfunction includes prostaglandin inhibition, interstitial nephritis, impaired renin secretion, and enhanced tubular water sodium reabsorption. 2. Many risk factors have been implicated, including congestive heart failure, HFE, chronic renal failure, CRF, cirrhosis, dehydration, diuretic use, and atherosclerotic disease in elderly patients. 3. Renal dysfunction is commonly manifested as abrupt onset oliguria with sodium water retention. The effect reverses after discontinuation of the NSAID. D. Malignancies and lymphoproliferative disorders. Agents that block TNF may affect host defenses against malignancies because TNF mediates inflammation and modulates cellular immune response. Lymphomas have occurred more frequently in patients receiving TNF blocking agents than in controls. E. Infections. Opportunistic and serious infections leading to sepsis and death have been associated with leflunomide and the TNF blocking agents. F. Miscellaneous effects. 1. Even in normal doses, acetaminophen can cause hepatotoxicity in patients with liver disease or chronic alcoholism. Hepatotoxicity has also been reported with the use of all NSAIDs, including the COX-2 selective inhibitors. Leflunomide and infliximab have also been shown to cause transient elevations in liver function tests such as aspartate aminotransferase ASTI, serum glutamic oxaloacetic transaminase SCOT, and alanine aminotransferase ALT, serum glutamic pyruvic transaminase SGPT. 2. Some patients exhibit acute hypersensitivity reactions to aspirin. Manifestations include either a rhinitis or asthma presentation or a true allergic reaction, for example, urticaria, wheals, hypotension, shock, syncope. A cross-sensitivity to other NSAIDs may develop. 3. Some NSAIDs produce central nervous system CNS effects, including impaired mentation, headaches, and attention deficit disorder. 4. Leflunomide has received a black box warning because of its Category X pregnancy warning. It has also been associated with weight loss, alopecia, rash, and anemia. 5. TNF blocking agents have been associated with reactions at the injection site and autoantibody production. 6. Celecoxib, a selective COX-2 inhibitor, has a black box warning U.S. Food and Drug Administration, FDA, warning from the because if it's linked to an increased risk for 1024 Chapter 51 Tech A. Cardiovascular events, heart attack and stroke. This increased risk has been demonstrated to be a drug class effect for all NSAIDs, excluding aspirin. Celecoxib is also contraindicated in patients with sulfonamide allergy. NSAIDs for short or long-term use are not advised in patients with established cardiovascular disease, particularly in those who have had a myocardial infarction, MI. A nationwide cohort study in patients 30 years of age who were hospitalized with their first-time MI from 1997 to 2006 found that even short-term treatment with most NSAIDs was associated with an increased risk of death and recurrent MI. Among the NSAIDs studied, diclofenac was associated with the highest risk. 5. Drug interactions. Salicylates have two clinically significant drug interactions. A. Oral anticoagulants. Aspirin should be carefully monitored if used in anticoagulated patients because it inhibits platelet function and can cause gastric mucosal damage. This can significantly increase the risk of bleeding in anticoagulated patients. Also, doses of 3 grams a day of aspirin produces hypoprothrombemia. Choline magnesium trisalicylate or acetaminophen can be used if a non-narcotic is needed in an anticoagulated patient. B. Methotrexate. Salicylates may enhance the toxicity of methotrexate. The primary mechanism is blockage of methotrexate renal tubular secretion by salicylates. The resultant methotrexate toxicity has been reported as pancytopenia or hepatotoxicity. Salicylates should be avoided in patients receiving methotrexate. C. TNF blocking agents. Anakinra, Kineret, a recombinant interleukin-1, IL-1 receptor antagonist, has been observed to cause an increased risk of serious infections as neutropenia when used concomitantly with etanercept in patients with rheumatoid arthritis. Consequently, its use is not recommended concomitantly with any TNF blocking agent. B. Narcotic analgesics include the opioid drugs, Table 51-2. Because of their abuse potential, opioids are classified as controlled drugs. Special regulations control their prescribing. 1. Mechanism of action. A. Endogenous opiates afford the body self-pain-relieving mechanisms. These endogenous peptides include the endorphins, enkephalins, and dynorphins. Table 51-2. Some commonly used opioid analgesics. Drug parenteral dose, mg oral dose, mg duration, HR. Morphine 1064-7 morphine, CR, MS contin. Not applicable 12, 24 hydromorphone, dilaudid, 1.37.546 oxymorphone, numorphin 1, 4,6 levorphanol, levodromerin. 2447 methadone, dolafene, 1024, 6 meperidine, demerol, 75-303, 6 fentanyl, sublamaze, 0.1, 12 fentanyl, transdermal duragesic, not applicable. Not applicable 48, 72 codeine, 130-204, 6 hydrocodone, 5-10-4-5 hydromorphone ER, Axalgo, 16-24 dihydrocodinab, 32-4-5 oxycodone, 5-10-4-5 oxycodone, ECR oxycontin. Not applicable 12-24 nalbuphine, Nubain 10, 4-6 butorphanol, Statol 2, 4-6 desicine, Dalgan 10, 4-7 buprenorphine. Not applicable 168. A doses equivalent to 10 milligrams intramuscular or subcutaneous morphine. B. Doses for moderate pain, not necessarily equivalent to 10 milligrams morphine. CR. Controlled release. Not applicable. Not applicable. AIR. Extended release. Pain management 1025. B. Exogenous opiates are classified as agonists, stimulate opiate receptors. Antagonists displace agonists from opiate receptors, and mixed opiates, agonist, antagonist, or partial agonist actions. C. Opiate receptors are located in the brain and spinal cord. Several types of opiate receptors have been identified, including and D. Stimulation of receptors produces the characteristic narcotic, morphine-like effects. 1. Analgesia. 2. Meiosis. 3. Euphoria. 4. Respiratory depression. 5. Sedation. 6. A physical dependence. 7. Bradycardia. E. The specific mechanism, central and spinal, of opiate agonist is alteration of the effects of nociceptive neurotransmitters, possibly norepinephrine or serotonin. 2. Clinical use. A. Opioid analgesics are used for the management of moderate to severe pain, acute or chronic pain, of somatic or visceral origin. B. The use of narcotics should be individualized for each patient. The optimal analgesic dose varies from patient to patient. Each analgesic regimen should be titrated by increasing the dose up to the appearance of limiting adverse effects. Changing to another analgesic should occur only after an adequate therapeutic trial. C. The appropriate route of administration should be selected for each patient. 1. Oral administration is the preferred route, particularly for patients with chronic, stable pain. Controlled-release morphine and oxycodone tablets are available for convenience in controlling continuous pain, particularly in those patients with cancer. 2. Intramuscular and subcutaneous administration are very commonly used in the postoperative period. Fluctuations in absorption may occur, particularly in elderly or cachectic patients. 3. Intravenous IV bolus administration has the most rapid, predictable onset of effect. 4. IV infusion is used to titrate pain relief rapidly, particularly in patients with unstable chronic pain. Morphine is most commonly used, often with supplemental IV bolus doses for breakthrough pain. A mechanical infusion device is necessary. 5. IV PCA is most often used for acute postoperative pain. It produces prompt analgesia with minimal side effects because small doses, for example, 1 to 2 milligrams morphine, are delivered at frequent intervals, for example, every 10 mins. It allows patient control of pain management. Morphine and meperidine are the most commonly used agents. A mechanical infusion device and properly trained patient and staff are necessary. 6. Epidural and intrathecal administration are used for acute postoperative pain and early management of chronic cancer pain. All drugs used epidurally or intrathecally must be preservative-free because of the neurotoxicity of parabens and benzyl alcohol when administered via these routes. Intrathecal doses are generally 1/10 of the corresponding drug's epidural dose. A. Low opiate doses stimulate spinal opiate receptors and reduce the amount of narcotic reaching the brain. This results in delayed or minimal effects such as sedation, nausea, and respiratory depression. The opiate distribution that causes such effects depends on the site of spinal injection, water solubility of the opiate, and volume infused. For example, after lumbar administration of a more water-soluble opiate, morphine, severe respiratory depression can be observed 12 to 24 HRS after initial dosing. B. Local side effects of intrathecal opiate administration are itching and urinary retention. Depending on the opiate used and the type of pain being treated, intermittent doses or continuous infusions via a mechanical infusion device can be used. Tables 51-3 and 51-4. 7. Rectal administration is an alternative for patients unable to take oral narcotics. Generally, poor absorption results in an unreliable analgesic response. It is an unacceptable route of administration for many patients. 1026 Chapter 51 to 70. Transdermal administration is an alternative for patients with chronic pain who are unable to take oral narcotics. A controlled release patch is available for fentanyl. Slow onset requires additional analgesia when starting treatment. The duration of analgesia is 48 to 72 HRS per patch. A slow reduction of effect follows removal of the patch and requires 24 to 36 HRS of monitoring. Patients who have chronic pain or acute pain that is constant throughout the day should receive regularly scheduled, around-the-clock doses of narcotics. 1. Long-acting opiates, for example, controlled-release morphine and oxycodone, are preferable. 2. A supplement given as needed may be necessary to manage breakthrough pain, for which short-acting opiates, for example, immediate-release morphine, hydromorphone, are preferable. If frequent supplements are required, then the around-the-clock regimen should be adjusted based on morphine equivalence, Table 51-2. Although the analgesia and side effects of opiates are qualitatively similar, individual patients may respond differently. Analgesic selection is based on 1. Patient's past analgesia experience, 2. Need for a rapid onset of effect, 3. Preference for a long or short duration of action, 4. Preference for a particular mode of delivery, 5. Preference for a particular dosage form, A. Controlled release morphine or oxycodone for a long duration of action, 8 to 12 HRS, may be preferable to opiates with long half-lives, for example, methadone, levorphanol, which can accumulate and cause overdose symptoms, for example, respiratory depression. B. Transdermal fentanyl can be used for patients who are unable to swallow. Rectal suppositories can be used for patients who are unable to swallow. They are available for morphine, hydromorphone, and oxymorphone. D. Concentrated hydromorphone injection, 10 mg ml, can be used for cachectic patients who require subcutaneous injections and in patients whose injection volumes must be minimized. Table 51-3 Epidurally administered preservative-free opioids. Intermittent dosing. Onset of action time to peak. Drug dose mg, min effect, min duration, HR. Morphine 5, 10, 25, 60, 12, 24 fentanyl 0.15, 10, 26 meperidine 50, 105, 10, 15, 37 hydromorphone 1, 10, 15, 20, 12 buprenorphine 0.3, 30, 40, 68, 9. Table 51-4 Epidurally administered preservative-free opioids. Continuous infusion. Infusion concentration. Drug initial bolus dose mg, mg/ml rate, mg/hr. Morphine 2, 0.05, 0.25, 0.2, 1.5 fentanyl 0.05, 0.1, 0, 0.0, 0.5, 0.0, 0.025, 0.02, 0.15 meperidine, 50, 110, 25, 20 hydromorphone 0.5 on 0.02, 0.0.05, 0.15, 0.30. Pain management 1027. 6. Individual sensitivity to side effects, which includes nausea, euphoria, sedation, and respiratory depression. A. Partial agonists or mixed agonist, antagonists, may be preferable for acute pain management in patients at risk for respiratory depression secondary to opiate agonists. These agents should not be used in patients who have received chronic doses of opiates because withdrawal symptoms will occur. B. Epidural administration may be preferable for critically ill patients at risk for respiratory depression secondary to systemic narcotic administration. 3. Adverse effects. All narcotics can produce a variety of side effects that range from bothersome to life-threatening. Constipation occurs as a result of decreased intestinal tone and peristalsis. There is a patient variability, but generally most patients experience constipation after several days of therapy. Constipation may be more bothersome with certain types of opiates, for example, codeine. It may occur sooner and be more problematic in hospitalized or bedridden patients or in patients who have received anesthesia or drugs with anticholinergic effects. Prophylaxis with a laxative stool softener combination, for example, bisacodyl docusate, Gentlax C, and dietary counseling, are warranted for patients who need chronic opiate therapy. Nausea and vomiting occur owing to central stimulation of the chemoreceptor trigger zone. It is more problematic with one-time or intermittent parenteral dosing for acute pain. Occasionally, patients require concomitant therapy with an antiemetic, for example, hydroxyzine, prochlorperazine. However, these agents may add to the sedative effects of opiates. Sedation is a dose-related effect, but sometimes is enhanced by concomitant use of other drugs with sedating effects, for example, benzodiazepines, antiemetics. Most chronic pain patients become tolerant to this effect, but occasionally the addition of a CNS stimulant, such as dextroamphetamine or methylphenidate, is needed. 1. Patients starting therapy with narcotics should be warned about driving or operating machinery. 2. Sedation may be a sign of excessive dosing or accumulation. However, sedation should not be confused with physiological sleep in patients who have pain control difficulties. Patients in pain often develop insomnia. When pain is brought under control by appropriate narcotic titration, the patient initially may sleep for several hours. Respiratory depression is the most serious adverse effect accompanying narcotic overdose. Respiratory depression may be a sign of an excessive dose, accumulation of long half-lived opiates, for example, methadone, levorphanol, or accumulation of active morphine metabolites in renal failure patients. 1. Respiratory rate should be carefully monitored in patients receiving IV or epidural opiates, in neonates, in elderly patients, and in patients receiving other drugs that cause respiratory depression. 2. The opiate antagonists, naloxone and nalmefene, are administered intravenously to reverse life-threatening respiratory depression. Use of naloxone or nalmefene Ravex in an opiate-dependent patient, for example, a chronic cancer pain patient, can precipitate opiate withdrawal. Anticholinergic effects, such as dry mouth and urinary retention, can be bothersome for some patients. Hypersensitivity reactions such as itching owing to histamine release can occur secondary to opiate use, particularly with epidural or intrathecal administration. Wheals sometimes occur at the site of morphine injection. These reactions do not represent true allergy. CNS excitation, such as myoclonus and other seizure-like activity, can be produced with the use of meperidine in renal failure. These symptoms have also been observed in patients with normal renal functions who receive high doses of meperidine, for example, 800 milligrams day of intramuscular meperidine. The accumulation of the metabolite normeperidine is the cause. 4. Drug interactions. Narcotics have additive CNS depressant effects when used in combination with other drugs that also are CNS depressants. For example, alcohol, anesthetics, antidepressants, antihistamines, barbiturates, benzodiazepines, phenothiazines. 1028 Chapter 51-2. BB narcotics, particularly meperidine, can cause severe reactions such as excitation, sweating, rigidity, and hypertension in patients receiving monoamine oxidase (MAO) inhibitors. Meperidine should be avoided, and other narcotics started at lower doses in patients being treated with MAO inhibitors. 5. Tolerance means that increasing doses of opiate are needed to maintain analgesia. Tolerance usually develops to the analgesic, sedative, and euphoric effects of opioids, but not to the pupillary constricting and constipating effects. This is usually observed as a decreasing duration of analgesia in chronic pain patients. The addition of an NSAID may help delay or provide adequate analgesia in tolerant patients. 6. Dependence. The use of opiates for chronic pain may result in physical dependence, such that the abrupt discontinuation of the opiate results in the development of withdrawal symptoms. Withdrawal symptoms include anxiety, irritability, insomnia, chills, salivation, rhinorrhea, diaphoresis, nausea, vomiting, GI cramping and diarrhea, and pelerection. 1. The appearance and intensity of withdrawal symptoms vary according to the half-life of the opiate. For example, the withdrawal symptoms after discontinuation of chronic methadone may take several days to develop and may be less intense than those of withdrawal from morphine owing to its shorter half-life. 2. The development of tolerance may be associated with withdrawal symptoms. 3. The use of naloxone or a partial agonist-antagonist such as pentazocine in a patient receiving chronic opiate therapy produces acute withdrawal. B. The development of physical dependence seen in chronic pain patients is not the same as psychological dependence or addiction. Also, the drug-seeking behavior observed in many acute pain patients, that is, from postoperative pain, is not a sign of addiction, but rather a need for adequate pain relief. Studies suggest that the addictive rates for long-term treatment of non-cancer pain are low in patients without a prior history of addiction. The analgesic needs of this type of patient should be reassessed and usually necessitates increasing the dose of opiate, changing to a longer duration drug, changing to a PCA, or adding an analgesic adjunct. See adjuvant analgesics and miscellaneous analgesics. Adjuvant analgesics are drugs whose initial FDA-approved indication was for a condition other than pain. Other classes of drugs affect non-opiate pain pathways and may be useful in certain types of pain, for example, neuropathic pain. These drugs often are used with other analgesics, and some may help manage narcotic side effects. Table 51-5. 1. Neuropathic pain agents include anticonvulsants, for example, gabapentin, pregabalin, lamotrigine, carbamazepine, systemic local anesthetic agents, for example, 5% lidocaine, lidoderm, patch, and tricyclic antidepressants, such as amitriptyline, nortriptyline, and dizipramine. Gabapentin and systemic local anesthetic agents are considered first-line therapy in treating polyneuropathies. Anticonvulsant can be used for lancinating neurogenic pain, for example, trigeminal neuralgia, phantom limb pain, post-trauma neurogenic pain. Tricyclic antidepressant and anticonvulsants are also used to treat migraine pain. A mechanism of action. 1. Gabapentin and pregabalin may relieve neuropathic pain by the presynaptic binding of the -2 subunit of voltage-sensitive calcium channels. 2. Pregabalin may also modulate the release of the sensory neuropeptide substance P3. Lamotrigine and carbamazepine are believed to block sodium channels at the site of ectopic discharge of damaged nerves. 4. The use of local anesthetics allows for local pain relief without systemic toxicity. Specify Kali by binding to the sodium channels in the damaged nerves. 5. It is hypothesized that TCAs obtain their analgesic effects as a result of sodium channel blockade at the site of ectopic discharge in the peripheral nerves. 6. All of these agents are recommended to aid in the reduction of neuronal hyperexcitability, whether it is peripherally or centrally. B. Clinical use. 1A data are available to give guidance on which agents to use to treat neuropathic pain, but they do not predict which agent will provide relief for each individual patient's pain. Pain Management 1029. Table 50 -5 analgesic adjuncts and miscellaneous analgesics. Drugs dose maximum indications, comments. Tricyclic antidepressants. Amitriptyline 10 mg day, 250 mg day, used at bedtime and started at low dose. Contraindicated in patients with urinary retention, glaucoma, and bundle branch block. Severe anticholinergic effects and weight gain can be limited. Nortriptyline 10 mg day, 125 mg day, doxepin 10 mg day, 250 mg day, clomipramine 10 mg day, 250 mg day, dizipramine 10 mg day, 200 mg day. Anticonvulsants. Valproate 250 mg BID, 500 mg TID QID. High teratogenicity incidence gabapentin 100 mg TID or 300 mg. EHS 300 1000, 200 mg TID. No blood monitoring required. Pregabalin 100 mg TID 300 mg day. This dose is for neuropathic pain. Topiramate 25 mg day, 100 mg day. Slow titration minimizes adverse events, weight loss, and metabolic acidosis are common. Phenytoin 300 mg day. Cosmetic side effects. Carbamazepine 100 mg day, 600 mg TID. Needs to monitor complete blood count, CBC, and liver function tests, DLFTs. Neuroleptics. Fluphenazine 2, 20 mg 30 mg day. Refractory neurogenic pain. Pain complicated by delirium or nausea, prochlorperazine. Prochlorperazine 5, 10 mg TID QID. 10 mg QID. Haloperidol 0.55 mg Q2 12 HRS 30 mg day. Corticosteroids. Dexamethasone 1, 4 mg BID QID, 24 mg day from neural infiltration. Pain associated with bony metastases. Antihistamines. Hydroxyzine 25 100 mg Q4, 6 HRS. Pain complicated by anxiety or nausea. Benzodiazepines. Alprazolam 0.25, 2 mg TID QID. 4 mg day pain complicated by anxiety lorazepam 0.5, 2 mg TID QID, 10 mg day, or muscle spasm clonazepam 0.5, 2 mg BID QID, 4 mg day, amphetamines and amphetamine-like agents, dextroamphetamine 15 mg BID TID 5, 60 mg day for excessive opiate, induced sedation in chronic pain patients, methylphenidate 5 mg, 20 mg BID TID 65 mg, 1030 Chapter 51 Took. C2. Typically, a treatment algorithm may recommend A. First line, I. Gabapentin T. Pregabalin, FERD 5% lidocaine patches, IV TCAs, B. Second line, I. Other anticonvulsants, lamotrigine or carbamazepine, i.e. other antidepressants, bupropion, citalopram, paroxetine, venlafaxine, imipramine, DU. Other I. Capsaicin, clonidine. See adverse effects. The most common adverse events associated with anticonvulsants are dizziness, headaches, and drowsiness. Lamotrigine has been associated with the development of Stevens-Johnson syndrome, SJs. It is recommended that lamotrigine be titrated up every 2 weeks to minimize the occurrence of SJs. 2. Tramadol Ultram is an oral, centrally acting analgesic with weak opiate activity. It has not been placed in a controlled drug schedule. A mechanism of action. 1. Tramadol is a synthetic aminocyclohexanol that binds to opiate receptors, inhibiting norepinephrine and serotonin. 2. The analgesic effects are partially antagonized by naloxone. B. Clinical use. Tramadol is used for moderate to moderately severe pain. 2. The recommended dosage is 50 to 100 mg every 4 to 6 HRS, up to a maximum of 400 mg day. The extended release formulation, Ultram Air, is given at a dose of 100 to 300 mg day. 3. At maximum dosage, tramadol appears no more effective than acetaminophen, codeine combinations. See adverse effects. 1A GI effects include nausea, constipation, and dry mouth. 2. CNS effects include dizziness, headache, sedation, and seizures overdose. 3. Diaphoresis D drug interactions. 1A tramadol can increase the sedative effect of alcohol and hypnotics. 2. Tramadol inhibits monoamine uptake and should not be used with MAO inhibitors. 3. Tramadol used with selective serotonin reuptake inhibitors, SSRIs, and other agents that increase serotonergic activity can cause serotonin syndrome, which is characterized by irritability, anxiety, CNS excitation, and myoclonus. D agents used to treat migraine. See Table 51-6. 1. Triptans include sumatriptan, zolmitriptan, naratriptan, rizatriptan, omotriptan, elatriptan, enotriptan, and A mechanism of action. Triptans are 5-hydroxytryptamine, 5-HT, 1-BA receptor agonists. One hypothesis for the efficacy of triptans in migraine is that activating 5-HT 1B receptors can lead intracranial blood vessels constriction. B. Clinical use. Triptans are effective for acute treatment of migraine, but not used as a prophylaxis treatment. Triptans should be used as soon as possible after onset of migraine attack. C. Adverse effects. 1. Cardiovascular, CV effects include rare but serious transient myocardial attack, coronary artery vasospasm, myocardial infarction, and atrial and ventricular arrhythmia. 2. Minor adverse events of sumatriptan injection. Irritation at the injection site. However, orally administered triptans can cause paresthesias, flushing, feeling of pressure, tightness or pain in the chest, neck, and jaw. 3. Zolmitriptan has an incidence of recurrent headache similar to that seen with oral sumatriptan. 4. Naratriptan may have a lower risk of headache recurrence than other oral triptans and has a lower incidence of side effects than sumatriptan and most other oral triptans. Pain Management 1031. Table 51-6 agents used to treat migraine. Drug initial dose daily maximum dose comments. Serotonin agonists, triptan, sumatriptan. Subcutaneous 6 mg Snapchat 12 mg day may repeat after 1 HR. Useful when non-oral route of administration is needed. Sumatriptan, oral, 25, 100 mg PU 200 mg day may repeat after 2 HRS. Maximum recommended monthly dose for migraine is 18 tablets, 50 mg, or an equal amount. Sumatriptan, nasal, 20 mg nasally 40 mg day, may repeat after 2 HRS. Similar speed of action and effectiveness to oral sumatriptan. Zolmitriptan 2.5 mg day 10 mg day maximum monthly dose is 18 tablets, 5 mg each or equal amount. Naratriptan non 2.5 mg day 5 mg day, only triptan not contraindicated. With MAO inhibitors, rizatriptan 5, 10 mg day 30 mg day propranolol increase serum. Concentration of rizatriptan, which result in bradycardia, then use 5 mg dose, max 15 mg day. Omatriptan 6.25 or 12.5 mg day 2 doses in 24 HRS. Frovatriptan 2.5 mg day 7.5 mg in 24 HRS. Blockers. Propranolol 60 mg day 320 mg day benefits may lag 3 to 4 weeks. Nadolol 40 mg day 240 mg day timolol 10 mg day 40 mg day atenolol 50 mg day 150 mg day metoprolol 50 mg day 300 mg day. Calcium channel blockers. Verapamil 120 mg day 720 mg day widely used but weak. Evidence for efficacy benefits may be noted after 3-4 weeks on therapeutic dose. Nifedipine 30 mg day 180 mg day diltiazem 60 mg day 360 mg day nimodipine 20 mg day 60 mg day. Angiotensin converting enzyme inhibitors. Lisinopril 10 mg day for 1 week. Then 20 mg day. 40 mg day. D. Contraindications. Uonatriptans should be avoided in patients with familial hemiplegic migraine, basilar migraine, ischemic stroke, uncontrolled hypertension, ischemic heart disease, Prinzmetal angina, ischemic complications, cerebrovascular or peripheral vascular disease, and renal or hepatic disease. Drug interactions. Triptans are contraindicated in patients with near-term prior exposure to ergots alkaloid or other 5-HT agonists. Triptans, excluding elatriptan, frovatriptan, and 1032 Chapter 51 ticking. D-naratriptan are contraindicated in combination with monoamine oxidase inhibitors, MAOA. Because elatriptan is metabolized by cytochrome 450-3,4 enzyme, CYP3A4, it should not be used within 72 HRS of treatment with potent CYP3A4 inhibitors such as ketoconazole, itraconazole, nefazodone, trolandamycin, clarithromycin, nelfinavir, and ritonavir. 2. Blockers. Using blockers for prevention is effective in 60% to 80% of patients in reducing the severity and frequency of migraine attack by 50%. It is unclear how blockers prevent migraine, but their action is most likely related to inhibition of one receptors with secondary effects on serotonin, as serotonin plays an important role in the pathogenesis of migraine. Blockers with intrinsic sympathomimetic activity, ESA, such as pindolol and acebutolol, are less effective in the treatment of migraine. Blockers should not be used as initial therapy for migraine prophylaxis in patients over age 60 and in smokers. The use of blockers may be limited in patients with erectile dysfunction, peripheral vascular disease, Raynaud syndrome or disease, and in patients with baseline bradycardia or low blood pressure. They must be used cautiously in patients with diabetes mellitus, asthma, and those with cardiac conduction disturbances or sinus node dysfunction. 3. Calcium channel blockers, CCBS. In treating migraine, CCBS are used prophylactically. They decrease the frequency of the attack, have minimal effect on headache severity, and are generally not as effective as other agents. Also, the vasodilatory action of some calcium channel blockers may induce or worsen migraine attacks. Their mechanism of action is unclear, but excessive levels of intracellular calcium under ischemic condition can cause neuronal damage and cell death. Among these agents, verapamil is frequently the first choice for prophylactic therapy because of ease of use and a favorable side effect profile. After 8 weeks of successful therapy with CCBS, tolerance may develop that can be overcome by increasing the dose or by switching to a different CCB. CCBS are contraindicated in patients with heart block, hypotension, heart failure, and atrial flutter and fibrillation. 4. Angiotensin-converting enzyme inhibitors, ACE, and angiotensin receptor blockers, ARBs. Based on a double-blind, placebo-controlled crossover study in patients with 2 to 6 migraine episodes, lisinopril 10 mg day for 1 week, then 20 mg day significantly reduced the headache severity. ARBs such as candesartan had similar results. ACE inhibitors are contraindicated in idiopathic and hereditary angioedema and hypersensitivity to lisinopril. 5. Ergotamine and dihydroergotamine, DAA. Ergotamine and DHE bind to serotonin 5-HT1 receptors similar to triptans. Various ergotamine preparations are available alone or in combination with caffeine and other analgesics for oral, sublingual, and rectal use, whereas DHE is available for intravenous, intramuscular, subcutaneous, and intranasal use. Based on clinical trials, oral ergotamine alone failed to show efficacy in migraine relief. Ergotamine tartrate can cause pruritus, muscle weakness, paresthesia, visual disturbance, vascular spasm, and cardiovascular system disorder, angina, MI, arrhythmia. In addition, ergotamine may worsen nausea and vomiting that associated with migraine. As a result, ergotamine is used in relatively few patients because issue of efficacy and side effects. It is used in patients with prolonged duration of attacks, for example, greater than 48 HRS, and possibly frequent headache recurrence. Besides being a potent 5-HT1 receptor agonist, DHA45 is an alpha blocker that is a weaker arterial vasoconstrictor and more potent venoconstrictor than ergotamine tartrate. Also, it has fewer side effects than ergotamine tartrate. DHA is given intravenously for acute migraine in combination with antiemetic. Parenteral DHA45 should not be used as monotherapy. Miscellaneous agents. 1. Capsaicin, a component of red peppers, causes the release of substance P from sensory nerve fibers, resulting in prolonged cutaneous pain transmission, histamine release. An erythema because of reflex vasodilation. Repeated local application depletes the peripheral sensory C nerve fiber of substance P, resulting in pain inhibition. Topical capsaicin cream 0.025% or 0.075% has been shown to be useful in treating joint pain and tenderness in patients with arthritis. Other uses may include treating diabetic neuralgia, reflex sympathetic dystrophy, trigeminal neuralgia, notalgia paresthetica, psoriasis and Sorenland KPD, and long-wave ultraviolet radiation UVA, induced skin pain, and postherpetic neuralgia. Local toxicity may include burning, stinging, erythema, pruritus, and superficial skin ulcers. Capsaicin 8% patch, Cutenza, administered for 1 HR, can provide 3 months of relief for pain associated with postherpetic neuralgia. Significant dermal reactions have been associated with this formulation. 2. Glucosamine sulfate and chondroitin sulfate have been used with increasing frequency in the treatment of degenerative joint disease. Glucosamine sulfate appears to act as a substrate for and stimulant. Pain Management 1033 to the biosynthesis of glycosaminoglycans and hyaluronic acid for forming proteoglycans found in the structural matrix of joints. Chondroitin sulfate provides additional substrates for the formation of healthy joint matrix. Short-term side effects associated with glucosamine include GI problems, drowsiness, skin reactions, and headache. Further research is needed to validate their roles. Non-pharmacological pain management. Other therapeutic modalities for pain management include cognitive behavioral interventions and physical methods. These modalities are appropriate for interested patients, patients experiencing anxiety with their pain, patients who have incomplete relief from analgesic therapy, and patients who need to avoid or reduce analgesic use, for example, those with chronic non-malignant pain. 1. Cognitive behavioral interventions include education and instruction, simple relaxation, biofeedback, and hypnosis. 2. Physical methods include acupuncture, physical therapy, compression gloves, orthotic devices, heat and cold applications, massage, exercise, rest, immobilization, and transcutaneous electrical nerve stimulation, TENS,